Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Differences between Pemphigus vulgaris and Bullous Pemphigoid. Both are autoimmune vesiculobullous disorders of skin. It means autoantibodies from own body to own components of the skin, which leads to blisters. It is called autoimmune vesiculobullous blistering skin disease. Both are blistering diseases, both affects the skin, both are autoimmune only. What is the difference? Difference is autoantibodies in Pemphigus vulgaris is against desmoglein 1 and desmoglein 3. These desmogleins are components of desmosomes. Desmosomes are intercellular connections connecting one keratinocytes to other keratinocytes. Keratinocytes which make up the skin. Skin is made up of keratinocytes. Just like liver is made of hepatocytes, kidneys are made up of nephrocytes. These keratinocytes will be polygonal in shape because of these connections. Desmosomes which attaches one keratinocyte to other keratinocyte. Coming to Bullous Pemphigoid. Here autoantibodies are produced against own desmosomes components of dermoepidermal junction. In hemidesmosome, BPIG1 is inner plaque, BPIG2 is outer plaque. Here autoantibodies are formed against hemidesmosomes. So split will be at the level of dermoepidermal junction, that means subepidermal. Here split will be intraepidermal. Suprabasal split. Age group middle-aged 40 to elderly 60 years in vulgaris. More than 60 years, more elderly people in Bullous Pemphigoid 60 to 80 years. Location. Blisters occur mostly over mucous membranes of mouth, throat, genital area and skin. So Pemphigus vulgaris is a mucocutaneous blistering disorder. Bullous Pemphigoid is predominantly on skin in flexural areas like abdomen, thighs, axilla. Coming to oral involvement, already I told vulgaris is a mucocutaneous. So first oral mucosa will be involved often before the skin. Here oral mucosa is rarely involved, oral involvement. Here lesions are superficial, intraepidermal, easily ruptured vesicles and bulla because of flaccid, because it is occurring in intraepidermal suprabasal. So it will be very flaccid, superficial, easily ruptured, less itchy. In contrast to Bullous Pemphigoid, here tense, firm bulla frequently associated with significant pruritus. Why here bulla is tense? Because split is occurring deep in the dermoepidermal junction. Entire thickness of the epidermis will be tense, making bulla firm. Coming to histopathological examination. Here intraepidermal, remember Pemphigus vulgaris means intraepidermal. Pathology. What is the pathology? Acantholysis. Acantha means spine. Desmosomes are nothing but spinous processes which are called acantha. It will be lysed because of own antibodies, leading to separation of keratinocytes and split inside the epidermis. After separation, each cell will lose its polygonal shape and become rounded cell, which is nothing but acantholytic cell seen in Jung smear. These are not seen in Bullous Pemphigoid. Here the entire pathology is below the epidermis. Suprabasal layer. What is suprabasal layer? Stratum spinosum. The name itself is given because of this desmosomes, spinous connection between two keratinocytes. Stratum basal appears row of tombstone pattern. Why? Here also acantholysis occurs, desmosomes will be there. One keratinocyte is separated from another keratinocyte, but basal cells are also joined or connected to the dermoepidermal junction. This connection is intact. So each cell will appear like a tombstone, not becoming round 360 degrees. Below it is connected to dermoepidermal junction like a tombstone, separated each other parallelly, but below it is attached. Coming to direct, here in Bullous Pemphigoid, already I told you pathology is subepidermal. So subepidermal blistering will be seen in histopathology with inflammatory infiltrates, often eosinophils. Hence significant pruritus. Direct immunofluorescence will take skin piece and will perform immunofluorescence using sera containing antibodies, antigens, which antibody IgG and C3 deposits will be seen where intercellular connections are desmosomes, against desmosomes IgG and C3. So at the intercellular junctions, these antigens and complements will be seen in a fish net like pattern, fish net appearance in Pemphigus vulgaris. In direct immunofluorescence, fish net pattern. Coming to Bullous Pemphigoid, same IgG and C3 deposits along basement membrane zone where the pathology is subepidermal. Here it will be linearly arranged IgG C3. Here fish net like pattern of IgG C3. Intraepidermally, subepidermally. Here vulgaris is more aggressive, can be life threatening without treatment. If treatment is not given me with high dose of steroids and immunosuppressants suppressing the antibodies attacking our own desmosomal components, desmoglein 1 and 3, then mortality may increase to 10 to 50%. If treatment is given, it will reduce to less than 5% mortality. Here it is more indolent and less aggressive, BP. Better prognosis. Bullous Pemphigoid B better, Pemphigus P prognosis. Bullous Pemphigoid has better prognosis in contrast to Pemphigus vulgaris, worst prognosis. Here low dose steroids and topical treatment, it will respond well. Pemphigus vulgaris Nikolsky sign is positive, Bullous Pemphigoid negative. Jank smear, already I told, acantholytic cells will be seen. Nothing but a round cell with hypertrophic nucleus and basophilic cytoplasm. This cytoplasm is more densely basophilic towards the plasma membrane periphery, leading to perinuclear halo. This is called an acantholytic cell with hypertrophic nuclei, perinuclear halo, round keratinocyte with basophilic cytoplasm, more condensed towards periphery, more deeply stained towards plasma membrane. This is also called as mourning edges. This is nothing but an acantholytic cell seen in Pemphigus vulgaris, seen in by doing Jank smear bedside test. Acantholytic cells are not seen in Bullous Pemphigoid. Obviously, it won't be seen because it is a keratinocyte lying in epidermis. Bullous Pemphigoid pathology is below epidermis. Coming to complications, Pemphigus vulgaris can lead to sepsis because of secondary infections with streptococcus or staphylococcus, because of widespread lesions, superficial lesions which will erode easily and will be easily susceptible to secondary infections. In Bullous Pemphigoid, as there are tense intact bulla, less chances of infection, may result in secondary infection but may not progress to sepsis and mortality. Here already I told you mortality 10 to 50%, significant morbidity and mortality if left untreated. Here it is generally self-limiting, Bullous Pemphigoid. Coming to Nikolsky sign. It is positive in Pemphigus vulgaris. I already told you. What is it? A clinical sign elicited by applying lateral pressure with the thumb on the skin over a bony prominence. Normal skin. This shearing force dislodges the upper layers of epidermis from the lower epidermis, which indicates intraepidermal pathology, intraepidermal split. A positive Nikolsky sign indicates intraepidermal cleavage. Types mainly direct and marginal. Direct is nothing but eliciting over a normal appearing skin at a distant site away from the blister. If it is positive, it indicates the disease is severe. Why? At a distant location from the disease, still the normal skin is getting separated when we exert a shearing force. Then disease is severe. It indicates the severity of the disease. Marginal Nikolsky sign, in the name itself, remember there is margins close to the existing lesion. When a lateral pressure and shearing force is applied close to an existing lesion on a normal appearing skin, it is marginal Nikolsky sign. Remember N for Nikolsky sign, N for normal appearing skin. Next, pseudo Nikolsky sign. It will be similar to Nikolsky, but it is not a Nikolsky sign, also known as epidermal peeling sign, elicited on erythematous skin. There Nikolsky for normal skin. Here epidermal peeling sign for erythematous skin. Positive in SJS10 buns, bullous ichthyosiform erythroderma. Why it is a pseudo-Nikolsky sign? Because here the pathology is mainly necrosis of keratinocytes, not due to acantholysis of keratinocytes. If buns are very superficial layers of epidermis will get necrosed, and if we apply pressure over the erythematous skin, this necrosed superficial layers of epidermis will dislodge from deep layers of epidermis. Similar way like Nikolsky sign, but the skin is necrosed here, not acantholysis. So pseudo Nikolsky sign, epidermal peeling sign. Coming to microscopic Nikolsky sign, rubbing the surrounding normal appearing skin with an eraser to cause microscopic split. May be useful for taking biopsy. If no new lesions are there to take biopsy, surrounding the lesion on normal skin, we will rub with an eraser to cause microscopic splits, which we can't appreciate with normal eyes. We will take punch biopsy and see in microscope, and we will appreciate that split in the epidermis, suprabasal microscopic split. Modified Nikolsky or Bullous spread sign or Lutz sign, same. If no new blisters are there, we will create a new blister using old blister. We'll exert unidirectional pressure on an intact bulla, causing peripheral extension of the bulla beyond the marked margin. We will mark the margins of the old bulla. We'll apply an unidirectional pressure leading to peripheral extension of the bulla. Is nothing but bulla spread sign. B for bulla, B for intact bulla. Asbo-Hansen sign. It is nothing but just a variation of the Lutz sign. Here, when the bulla is very small in size, we will apply pressure on the bulla at the center. It will cause irregular angulated borders in Pemphigus vulgaris, rounded borders in subepidermal blistering diseases like Bullous Pemphigoid. If the borders are angulated, it is Pemphigus vulgaris. If it is round, subepidermal blister like in Bullous Pemphigoid. Asbo-Hansen sign, modification of Lutz sign or bulla spread sign. Both are performed on intact bulla. Now here intact bulla got ruptured. only the remnants of the roof are present. Pulling off peripheral remnants of the roof of a ruptured blister, thereby extending the erosion on surrounding skin. It is seen in subepidermal blistering disorders. This sign is called Shekhlakov sign or false Nikolsky sign. Remember, Nikolsky, N for normal skin, pseudo Nikolsky or epidermal peeling sign. E for epidermal, E for erythematous skin. We will perform on erythematous skin. Next, false Nikolsky sign or Shekhlakov sign. Here, peripheral remnant of roof is pulled, not applying a lateral pressure on normal skin. Just roof, whatever is left in the periphery is pulled, leading to erosion of the surrounding skin. Asbo Hansen sign and bulla spread sign. B for bulla, we will apply pressure on intact bulla. Remember the channel name, The Average Dermadoc. Don't forget to subscribe and share my channel. PDF of this will be provided in the description. Just click on the link, download PDF and read. Thank you. Hasta la vista. Das vidaniya.